Well, I don't know about you guys, but I'm both extremely excited and exhausted. It's been a beautiful couple days. I'll spend the last few minutes really, so I plugged in here, if the AV guy can plug this up, just a few minutes trying to help you consolidate what we've done over the last 20 hours of working. First of all, thank you so much to Justin Baker, who was the lead organizer of all of this year. And the whole ITP community, particularly Laura Germain and Ipsit Vahia and Mona Potter and their work, and most importantly, all of the assistants and RAs who really ran this for us, Nick Mirren, Praise Olema, Rose May, Luke Schurer, Eliza Passel, Laurel Meyer, Sarah Kimball. And thank you to Scott Roush for your support. So if we can just go to my computer here. So, nope. Sorry, this one? Justin, this is the one you said to plug in, but I don't know. Oh, there we go. Okay. So first of all, so I'm going to do a whirlwind of highlights and quotes from the last 2 days. So Scott started by celebrating the Red Sox. I wanted to give him the proper color hat here. I don't know where he got that thing that he was using. But we could also think of in Kofi's last comments, this could be the future of the EEG cap that he's going to sleep with. Scott talked about the inflection points in psychiatry and mental health that we're in right now, where we have these huge global unmet needs of greater than a third of the population having conditions, but so much lack of access, and really we're stuck in so many ways in our field. And it reminds him of the tipping point of MRI usage in the 25 years ago in neuroscience. And that this community is virtually unique in bringing clinicians, scientists, and cultures of academia, policy, and industry together. And as we were talking earlier today, almost none of us were raised in this field. This is a field that is so new that everybody is new to it, so it's really very exciting. Our first panel, Expanding Mental Health Care in Diverse Communities, Global and in the U.S., was led by Dr. Kim Leary of McLean and Harvard School of Public Health, talking about bringing cross-cultural therapeutics to a digital context, focusing on how do we best leverage technology to close gaps in access and equity, how do we situate in the context of culturally sensitive practice, using bidirectional communication of science, especially in underserved areas. David Moore from Northwestern focused on overcoming research in the practice gap in the digital mental health, with the observation that we have hundreds of RCTs now, but almost all of them are underpowered, not well controlled, and they're modestly effective at best. So our research in this area needs to improvement, and particularly our apps and our approaches have failed to design for the patient and failed to design for the care system. I always like all the new words that I learned. I don't remember if I knew gamification before, but we heard a lot about that during this 2 days. We also learned this great new word, skeuomorph, with the example of the candelabra chandelier and the ebooks, and that part of the way that humans are familiar with things is to keep with the approaches they're familiar with while adding or having behind the scenes the new technologies that are doing the new work. And we have to better design to fit in the fabric of patients' lives and provider workflows, and we have to keep remembering it's about providing service, not the technology. The technology is the means to the end. Kamal Jathwani from Partners talked about a number of examples where we can use technology within our healthcare systems, talking about real-time versus asynchronous, how do we store and go forward versus real-time approaches, virtual approaches, a number of different examples that are currently being used already within the large Epic systems that are used across the country, and ways to start combining and uploading these digital data into our Epic medical healthcare systems, allowing providers to see digital health data within the medical record. Vikram Patel of Global Mental Health and talked about the digital global mental health future and the importance of context. He riffed on the comment about hockey sticks, and simply a comment like that, with whether you're thinking of a country that's using them for ice hockey versus field hockey, you have very different interpretations. And the care systems in most of the world is no care system at all, particularly in mental health, and there's a huge digital divide continues. The importance of workforce interventions, engaging the public, the importance of how do we create, using large-scale cognitive data, cognitive normative growth curves, just like we have developmental growth curves, and how those sorts of approaches across our different behavioral structures will really lead us to better understand normal population curves and abnormality. And using tools like pyramidal population-based screening, within leading up to detection of atypical development, and then specialist referrals are going to be the kind of approaches necessary in large-scale countries where you're really doing large-scale rollouts. Shelley Greenfield of McLean and the president of American Academy of Addiction Medicine introduced the discussion and talking about the gaping chasm as large as a Grand Canyon and the importance of opportunities for digital health and personal solutions in healthcare systems. A couple of the interesting comments from that discussion was that digital tech allows assessment in a dimensional way. Kamal's example of the nurse avatar that actually did better than the real person because she had time to pay attention, and raising the question of, can our robots be better at aspirationally being human than we are, even though we think we're better at it, but most of us are too busy and too distracted. So, where there's risks and where there's maybe benefits in these approaches. Michelle Williams, Dean of the Harvard School of Public Health, talking about the promise to reality in harnessing technology, and with the point that improving public health must begin with improving brain health. Okay. And that we're at an inflection point in the mental health crisis, uniquely a point to ability to address it, and that we've got to increase affordability, decrease stigma, enhance outreach, and really making the point that public health equals mental health. And if we don't take care of mental health in our global health crisis, really we're not going to be able to take care of public health across all of the different disorders and diseases. Sandy Pentland from MIT, human life has become digital, reminding us that 20 years ago, a half had not made a phone call, and today 95% own phones. I was thinking at this turn of we're, I guess, well into the 21st century now, but about 100 years ago, at the beginning of the 20th century, you had whole populations of adults who were running everything, who were still thinking about their horses when all these new fangled car things were coming around, and how easy it is to forget how rapidly in our lifetimes entire ways and things we take advantage of change. And how computational science is really moving to a predictive science, and that's where we are as a field right now. Examples of deep mood with maintaining mental health depends on reciprocal interactions with other people. The great economist Adam Smith, reciprocal interactions create solutions for community, and Sandy really hypothesizing that really evolution is selecting for reciprocal interactions, and so that measuring relationships is so critical in the tools that we provide, and we can't let these digital tools take the relationships out of the key structures of humanity. Panel 2, we talked about de-risking. Dawn Sugarman from McLean, developing a digital therapeutic for co-occurring substance use disorders, and really walked us through the process from developing a great idea based on clinical knowledge all the way to how do you create the minimal viable product in the development process. Dave Epstein from NIDA, whose disclaimers that he's not in the pipeline at all, talks about just-in-time mobile devices and another new acronym, JITAI, Just-in-Time Adaptive Intervention. And really, how do you think about these interventions? When do you push the interventions? When is the app good enough? How do we predict behavior? And in the field, again, we've got to do better in terms of sensitivity, specificity, focusing on individual variation. We can do a lot of things, but if we're not really controlling for the right controls, does it beat placebo any interaction? Are we really doing much at all? And talked about micro-randomized trials and another new term, the Barnum effect, reminding us that people believe fortune cookies and horoscopes, and they're remarkably credulous at automated feedback. So we must be skeptical of how people take this information. Lisa Marsh from Dartmouth, some great examples of interactive modules to people with substance use disorders, and again, one of the most mature of these that's now had FDA authorization for the first prescribed digital therapeutics, really leading the way into how digital apps and digital therapeutics can take the next step with FDA and the importance of FDA with rigorous testing. And Aaron Josephson, from formerly of FDA and now a policy advisor, walked us through some of that process with the FDA's mission to protect and promote public health, how software fits within the medical device definition of this field, and how important it is for us to keep being aware in FDA's role in moving regulating projects to regulating the product developer. So really insightful about how we can both be, how the role of the FDA in both being skeptical and protecting the public. David Barash of GE Foundation gave a number of examples of how GE and other companies for public-private partnerships want to be involved. And one example is ECHO for PCPs to be educated about opiate treatment, and the DRIVES program for registering patients with chronic pain and substance use disorders. One of the a deep discussion about how do you translate face-to-face engagement into an actual app, and the question is that really the right question? because we may not need to perfectly mimic the face-to-face. It's maybe a different thing we're doing, but again, back to the idea of a skeuomorph. There's complementary, they don't have to necessarily be the same thing. Bill Carlazon from McLean brought us into translation with 2001 Space Odyssey, and another example of how future predictions, on the one hand, they're so far off of where we really are, and on the other hand, how disappointing it is that we don't really have as much as we would hope to. I don't know if Alexa is the current HAL or not, but and examples of mouse EEG that then sort of prepped us further for Koff's talk today, but ways we can use this continuous measurement in mice for all sorts of next generation digital phenotyping in mice, for example, estrous cycle activity measurements, early immune activation, and the great example of the Disney World wearable, where so much of these technologies are already being used in the world of industry, and why aren't we using them necessarily and to help make people better? Bob Data, reading the mind of a mouse, this great MOSEQ example that's just amazing, 3D imaging to inferential modeling to behavioral syllables, creating a parts list for behavior, and how we can also now start creating parts lists for human behaviors. Learned about marmosets from Roger Landeman and many equivalent approaches, and then Cameron Good, how we can translate some of these things in animal models of very real disorders like post-traumatic stress, the specific stress disorders, using a whole host of new technologies. And then Liz Phelps helped wrap it up from the human cognitive perspective, behavioral phenotypes to psychiatric disorders, how do we examine more naturalistic phenotypes? So again, a theme throughout all of this. On to naturalistic phenotypes on day 2. Cheryl Corcoran from Mount Sinai talking about natural language processing, an example of schizophrenia trajectory language. Particularly, we know about poverty of content, but how do we think about that in real-world linguistic analysis, and focus how by simply focusing on semantic and syntactic features, a whole host of predictive modeling can be performed. Guillermo Cecchi from IBM, that in many ways, the psychotherapy and psychiatry process hasn't changed in 100 years. Yes, we've got some medications. Yes, we have new formalized therapies, but basically people drive in and they have an hour appointment. And how we have to think about this. The examples of using language processing for predictive modeling of pain, and some of the philosophical ideas of Descartes, and I think therefore I am, in the Turing test of the language games, and are we getting to the point of where psychotherapy models is really going to be our Turing, the most modern Turing test of what it is to provide language-based feedback. Tom McCoy gave some great examples of using EHR data for RDoC type phenotypes. I particularly liked his pictures of Mount Depression versus Mount Mania from Blake 11, but that some of the RDoC domains identified based on these EHR-based natural language processing data have better prediction of GWAS than do depression itself. And then Sherry Turner showed a great example of a real-world use of this with this great crisis text line, 741-741, that already has 11,000 trained counselors and has had 63 million conversations. And really just a beautiful example of how an iterative database system continues to help enhance prioritization and risk and their goals for global expansion of some of these crisis lines. Jeffrey Gerard led the discussion from Carnegie Mellon, and again reminding us that clinical judgment and self-reports, what's everything based on, and yes, they're important, but they're so biased, difficult, and limited. If we can provide these objective tools, how much better will we be? Panel 5 on leveraging social and electronic communications. Ipsit Vahia talked about his living laboratory and how digital lives and mobile device interactions can be used in clinics. Sarath Guntuku from Penn, that a lot of data that patients are willing to share this data, and we can leverage large-scale imaging and text data for these approaches. Munmun Dashori from Georgia Tech, using social media to improve psychiatric outcomes, and the importance of questioning, looking at the compromise of accuracy and performance and focusing on trust. And then Benji Silverman gave us a great philosophical history of IRBs, even some Aristotle quotes, and talked about the importance of professionalism, informed consent, confidentiality, really maintenance of trust, and the basic tenets of keys to ethic with good ethical daily habits. What we have to keep in mind, but this is such an iterative process, and the field is changing so much faster than the rules and the regulations can keep up with it. Finally, we wrapped up with the future of behavioral forecasting with Justin Baker giving us example of N-of-1 designs, another new word, phenomics, to truly understand the phenotypes and the quantitative operationalization of future behavior, with their work on a year in a life of bipolar disorder using feature extraction to derive latent construct models, and how we need to move towards human-centered tools for a digital age, and that's another theme throughout. This great quote from a patient about risk forecasting, you'll never stop the violent autonomy of human behavior, and how we have to keep the human at the center of this. Kerry Ressler from Duke, who's envious of cardiologists. I think all of us in psychiatry in some ways are envious that and I think many of us who are in this room are envious that we don't have more quantitative tools, and that's why we're here, is prevention a viable therapeutic strategy. Talked about the importance of stable states, and on the one hand, things change rapidly, but on the other hand, at the tools we have now, they're relatively stable. Nobody complained about being sad for a millisecond. I couldn't help with, when you mentioned the electome, as Laura referred to as the mouse electoral database, my aspirational electoral college map over here. And as opposed to Bob Data, who yesterday said he was really not a very good mouse psychologist at all, Kafui is a very good mouse psychiatrist. So maybe that's part of the difference between can we describe behavior versus can we describe brain activity as one of the differences between these discussions. Sirajan Sid, this amazing cohort of, I think all of us who've gone through residency training can very much relate to these to your subjects and patients and future doctors, and really the great work of taking advantage of a cohort that is very invested in understanding, using it to predict vulnerability at risk and baseline with really a great prediction level, 0.85, but still very little value on the day-to-day predictions, and how we can incorporate broader set of tools to really get from biology to phenotype. And Adam really has done amazing work, very modest, from Yale and all sorts of great publications, founded Spring Health to do a lot of this work, and has really looked at the barriers to effective care where psychiatry is a field of opportunity, how we can use methods to large data sets, incorporate prediction algorithms and use 3 points, new technology to address problems in mental health. There are already many instances where these approaches can help, and it's doable in the real world. And I moved Bruce to the end because most of his final points would be my final points. So again, Bruce, who's really been a great leader in NIMH for decades, quoted the epistemic prison that we've been in our field with nosologies that then we have dogmatized, and how we have to be aware of the syndromes, the heterogeneity, the comorbidity, and the overspecification, and that these dichotomies can be resolved with technology. And I really thought, yes, he says RDoC is a framework, and I really think of it as a process for applying the scientific method to behavior. It's not a thing, it's a process. Common disorders are composed of quantitative traits, an example of translating temperament. We've put a lot of effort and thought into the 5-factor model, but the classic work's really much more dimensional and behavior-based, and that's really where we are right now, is how do we take this dimensional analysis of mammalian systems with all the kinds of tools we heard about from Kafui and the translational group yesterday, in parallel, take these models in humans and start to find where do we really have a new understanding of behavior. So I'll end with, again, another quote talking about interferon. He said, we don't call it depression because we know what's causing it. And what an ironic statement that is. And Justin, once you start having the ability to measure things, the field will change. And I think our goal should be through digital health and the power of modern tools and computation to have the precision, mechanisms, diagnosis, and targets so that very few of our patients will have to have a disorder that we don't understand the mechanisms and have targeted interventions. Thanks so much for spending these 2 days with us. It's been a great time. And now we have food and refreshments, so we can carry on the discussion for a while longer outside, food and refreshments. Thanks, everybody.